Good morning, everyone. I'm Wendy Tigalar, Director of Guardianship at AHR Suffolk on Long Island, AHRC Suffolk on Long Island. Welcome to this symposium session, the MOLST, our medical, ethical, and legal responsibility to improve quality and honor preferences. Thank you for remaining on mute and typing your questions in the chat for the end of the session. Our speaker, Dr. Pat Bomba, is someone who contributes to the well-being of her fellow humans in a unique way. And honestly, I could sing her praises for the whole session, but I'm gonna direct you to the program notes to learn more about her. I do wanna highlight that she founded the MOLST and eMOLST programs in New York State, and she is a tireless expert, educator, and advocate for these programs. Dr. Bomba brings a clear and thoughtful process and presence to a topic that can be intense and complex. Thank you for being with us, Dr. Bomba. We're excited to learn together today.
Thank you, Wendy and Erica and everyone at NYSARC for inviting me today. I'm just going to share the screen and get us started. So one of the key, I just need to move this out of the way so that it's not disturbing the slides. Our key objectives today, and I'm grateful to be able to be with you today, but I want to be able to, as you listen to me speak, take away ideas that you can identify and then implement opportunities to improve not only the use of MOLST, but advanced care planning in general for individuals with intellectual and developmental disabilities. We're going to demonstrate some of the elements of the 8-step protocol and how to effectively use it, because MOLST is more than a form. And we'll recognize how and why the legal requirements of the OPWD checklist must be completed. I'm going to focus more on the clinical end because I know you've heard this, but I'll integrate that in and then introduce you, if you're not familiar with eMOLST, and discuss how that basically improves quality and patient safety. And we have experience with individuals who part of the 1750B process, all working together using the eMOLST. So we're starting to start today by talking about starting advanced care planning earlier. I illustrate advanced care planning as a process and using this rainbow and thinking about people who may be able to identify a healthcare agent, but it's thought of too late in the process. And so we should be starting for everyone, ourselves included in the general population, as well as individuals with IDD, and begin to think about it in terms of who do they trust to make decisions, their healthcare agent, what matters most to them, and recognize that changes over the course of time as there is the presence of illness and it advances. And this, on this side of the rainbow, is where MOLST is appropriate. It's a set of medical orders, and it's not for everyone in the general population. It's certainly not for everyone in the population of individuals who have IDD. It's really, and we're going to talk at length about who is appropriate, who's not, but it really is for people who might die in the next year. They don't have to die on time, but they have multiple comorbidities and significant frailty. And so when we think of advanced directives, we're going to focus on healthcare proxies. And the critical reason that MOLST was created is that it's very, very difficult to interpret a living will in the midst of an emergency. And so medical orders, as you know, include resuscitation preferences. What do you want for respiratory support, hospitalization, feeding tubes? I want to start a little bit and talk about capacity. Everyone in the general population, as well as the population of individuals with IDD, are presumed to have capacity to choose a healthcare agent and complete a healthcare proxy, unless they have an Article 81 guardian, a 17A guardian, or the court has determined they're not capable legally of appointing a healthcare agent. So what does it mean by capacity? Capacity is task specific. An individual may not be able to make complex medical decisions like life-sustaining treatment on the MOLST, but they may be able to make simple decisions to accept treatment for a bladder infection or for palliation and pain control. But they also may have the ability to choose who do they trust to make decisions. So this is important to initiate early. It's also important to talk about what matters most. Who do you trust and what matters most? And it's important for all of us who care for these individuals to be able to go through the same process. If we go through it ourselves, it helps others to trust that this is an important process. And I found that that was important in my own practice. It was very important to people or my patients when I said, I've done this process multiple times. I've changed it when my life has changed. What matters most changes. Who I trust changes. And that really helps people to recognize how important it is. We created a program called Community Conversations on Compassionate Care that is complementary to MOLST. It's to help people to do healthcare proxies and early discussions, and it applies to the patients that you care for, the people with IDD, but also to yourself. It's based on behavioral readiness. Learn about it, and you're learning today. Why haven't you done it if you haven't completed your own personal healthcare proxy? What's keeping you from it, and how do you remove those barriers? How do you motivate yourself? It's through stories and recognizing what happens when you don't create it and understanding public health law. And we'll focus on that today for our population, but not the general population. And then doing it is putting it in writing, choosing the right person, talking about what matters most, and committing to updating it and reviewing it regularly. We do ours annually at our Thanksgiving conversations every year. It's a time when families gather together. It's a time that I encourage you to think about it. These are some bullets in terms of how to choose the right healthcare agent, but it's also helpful in terms of choosing the right guardian. And as supported decision-making comes into play, choosing those who will help support individuals to help make medical decisions. Clearly, it's someone that knows them, is participating in their care, can be, most importantly, separate what they'd want for themselves versus the individual, be available when the time comes, and most importantly, I found the ability to manage conflict, because conflict can occur within the family, between the family unit and the care team, or individuals on either end. So managing conflict is very, very important. When healthcare proxies are executed, it's important to recognize they need to be witnessed. If you're asked to witness it and you don't think that person is executing it willingly and free of distress, then please notify the CEO of the facility or MHLS or both so that one can move forward. In terms of witnessing, at least one needs to be a physician, NP or PA, or clinical psychologist that meets the same criteria that is involved in the MOLST process and 1750B and that checklist that you're familiar with from OPWDD in terms of completing the MOLST. And the reason for that is these are experts in terms of understanding capacity in this special population. The healthcare agent cannot serve as a healthcare agent and also as a witness. Now we're going to shift from healthcare proxies to MOLST. You're familiar with this pink form, but this is the end of a process. And it's a standardized communication process that we're going to walk through today. And it's based on today and what matters most to the person today based on what's happening to them from their health status, their prognosis, and it's based on shared decision-making. It's not autonomy. When I was in training, our decision-making was fairly paternalistic. Doctor knows best. We then shifted to autonomy, asking people what they want. And if we thought that that worked, then we should send everyone to medical school. But shared decision-making means we act together to help those decisions and help provide the important information. We need to follow ethical legal requirements. And under healthcare proxy law and Family Healthcare Decisions Act, it's the physician, nurse practitioner, or PA. But if it's under 1750B, those individuals who don't have a healthcare proxy, lack capacity, it's only the physician. And that's because 1750B has not changed. It's always crucial to document the discussion, and the end product is this pink form with a set of medical orders. It's not done at that point because you need to have a palliative care plan. And we're going to talk about why that's very important, and then committing to reviewing and updating it regularly, at least every 90 days, and anytime there's a change in health status. So let's talk about who's appropriate for MOLST. It's generally for people with advanced illness who require long-term care services. It can be in a facility run by OPWDD. It can be a nursing home or at home with long-term care services, and the person may die in the next year or two. It's also for individuals who wish to avoid or receive any or all life-sustaining treatment. And that applies for individuals with IDD who still retain capacity to make these decisions. Here are some examples of advanced illness, and I know you've seen these in the clients and the patients that you care for. It's also important to understand frailty. It's common in older adults. It can be common, and you can see that in the individuals you care for. But frailty alone is not a trigger. But as people have advanced frailty with low energy, the inability to walk and care for themselves, have unintentional weight loss, then that means their underlying disease is progressing. And we need to consider that. When we started the MOLST program, we started thinking in terms of clinical health status with the palliative performance scale. We found by working with our physicians and other care team members that didn't work. And so we started to use the clinical frailty scale that's been well developed and studied in Canada. And as you look at this, I want you to recognize that this will be integrated into the teaching as well as in the eMOLST application. So an individual that you're caring for who got mild frailty or moderate frailty, they're not necessarily they're not appropriate for MOLST unless they have significant end-stage advanced illness. But someone who is severely frail and at risk of dying within the next year, but they're not going to recover even from a minor illness, they would be appropriate. People who are severely ill, but they're not at risk of dying and they may live for several more years, are not appropriate for MOLST. When you see dementia, it tends to align with the degree of frailty. So who are the individuals at highest risk? These are people where you're coupling advanced illness and advanced frailty, and you know them. They are individuals who are going back and forth to the hospital. And as they're in the hospital, their frailty worsens, their functional status declines, their ability to participate in activities decline, and they're at high risk for dying. These are the individuals that should be offered the opportunity to learn about and complete the MOLST, and not just rely on the surrogate to raise that as an issue. And it's important to recognize that there may be individuals that are asked to complete a MOLST that are not appropriate. Doing prognostication is difficult in both the general population as well as in individuals with IDD. And I always said to people, I don't know the hour and time of death, but I can tell you it wouldn't surprise me if they die in the next year or in the next 6 months and they're eligible for hospice, or really in the next days to weeks. And so it's important to prognosticate so people have an opportunity to get their affairs in order. Who's not appropriate for MOLST? And this is equally important because there are times where people think that people are appropriate for MOLST. A form is completed, the 1750B process is not completed, the checklist isn't done, which needs to be attached to the MOLST, and it's done oftentimes when the guardian themselves have a severe a severe illness, an advanced illness, or at high risk for dying, and they really truly want to make sure their loved one does not suffer at the end of life. MOLST is not appropriate in that situation. And it's not appropriate for individuals who only have IDD, but no advanced illness. So just to summarize, all seriously ill persons in the general population, as well as those with intellectual or developmental disabilities, deserve and have a right to receive palliative care, and it's important to recognize all seriously ill people with IDD are not appropriate for MOLST. They may still have extended life expectancy. But you need to consider these in these situations and recognize that OPWDD has approved use of the MOLST and also encourage completion of healthcare proxies. So if you're not using it, I encourage you to use the 8-step protocol. And if you're using only the non-hospital DNR, I strongly encourage you to move to MOLST. The non-hospital DNR only applies to what does the person want if their heart stops, they stop breathing, and they've died. Do they want to attempt at resuscitation or allow a natural death? But there's so many other important decisions that people with advanced illness need to consider. And MOLST is the only form that EMS can follow in the community. It's the only form that has been tested for 3 years under a legislated community pilot from 2005 to 2008. You cannot add DNI, do not intubate, onto the non-hospital DNR form and expect the EMS to follow it. And again, with MOLST, you must attach the OPWDD checklist for that population who lack capacity and don't have a healthcare proxy. MOLST is about having a discussion or a series of discussions. It may not be one and done. And we'll talk about that through this session in terms of process. We recognize some of the communication challenges, and while this process takes time in the general population, some of the communication challenges and the tools you have to overcome them need to be used in completing the MOLST. And so it's important that it's done correctly. I know you've known that it's difficult to be able to even assess symptoms and manage them sometimes because of these challenges. We also know that there's not the same level of medical evidence that's specific to this population, particularly those living in community residence. But the reality is people with IDD have the same medical conditions. They are individuals. So advanced heart disease is going to be the same in those individuals. Multiple comorbidities are going to impact them the same. It's also important to recognize some of the emotional challenges because people may not recognize their illness and they may think it's because they did something wrong, and they may not understand why their loved ones are sad if they're approaching end of life. Helping the individual, the healthcare agent, or the guardian prepare for a MOLST discussion is most important. These are a list of questions, and you will have the slides to be able to go over these to share in helping someone prepare for a discussion. And we have resources at the end in terms of websites and videos that can also help prepare the individual for a MOLST discussion. This is the protocol, and you'll see it's only step 7 that you actually complete the MOLST. The first is preparing for the discussion, understanding that person's health status, their prognosis, their ability to consent to these medical orders, their capacity. Do they have advanced directives? Were they able to complete a healthcare proxy upstream? Who's the decision maker? If they have guardianship papers, does it include healthcare decision making? And what are the public health requirements? As you start the discussion, it's important to understand, what does the patient know? What does the family know? What does the decision maker know? What do they understand from previous discussions from the previous medical team? What do they hope to accomplish? What are their hopes, their goals for care? What are their expectations? And are they realistic based on where they are? If someone is hospice eligible and has a prognosis of less than 6 months, and the patient and or medical decision maker or loved ones think that they are going to meet a life goal in 5 years, then that's an unrealistic expectation. So it's important to respond with both sides of your brain, not only talk about what the real medical conditions are, but to use empathy and compassion and be wise in these discussions and help people through. And don't move to the MOLST until they truly understand what is happening today. MOLST is then used, and we're going to talk about the choices to help finalize through shared decision-making and resolving any conflicts, the medical orders. And it's only then that you need to follow this public health law. If it's a healthcare proxy, there's checklist 2. If it's 1750B, the process needs to be completed and documented. There need to be no conflicts and no objections raised by either the facility director, OPWDD, or MHLS. And after that, only after that, can the physician, and if it's again 1750B and the checklist, only the physician can sign the MOLST form. And then reviewing and revising periodically, because life changes. Medical orders change. A good thing to think about is if you have a bladder infection, a urinary tract infection, and you start an antibiotic and it doesn't work, you're not committed to that. You change antibiotics. If you're being treated for cancer and one treatment isn't working, you change it. That's why it's important to review and renew these medical orders periodically, particularly when people have a change in health status, when they have a change in care transition, they move from one setting to the other, or they change their mind. These are the key checklists. There are 5 for adults and 2 apply to individuals with IDD. There are individuals, again, who have capacity. They make their own decisions. They stand in their own shoes and say, this is what I want and don't want after that discussion. If there's a healthcare agent, then they make decisions in accordance to what the patient would want, and guidance and capacity needs to be determined. But it's much simpler than the process under 1750B. And that's why I'm encouraging you to encourage people to complete healthcare proxies when they have the ability to do so. And then for those who don't have that ability, then we have the OPWDD checklist for MOLST. This process starts with either a recommendation or a request from a surrogate for withdrawing or withholding life-sustaining treatment. The checklist then makes sure that you determine capacity, you have a concurring opinion, you get consent, and you talk about it. And I should have written treatment to be withdrawn or withheld, because we always take care of people, but there are certain treatments that may or may not no longer be helpful, and they're appropriate to talk about withdrawing or withholding. And then providing notice to the patient, to MHLS, residential provider, and or OPWDD based on whether they live in a facility or live at home. And it's important that the checklist, relevant medical records, and the draft MOLST is provided. And then there are no objections, and then medical orders can be entered. And again, when they cross a care transition, the MOLST must be accompanied by the checklist for the individuals who lack capacity. Let's talk about the care plan, which is an important step in terms of individuals who particularly no longer want to go to the hospital and have made decisions to forego respiratory support, resuscitation. It's important that there's a good palliative care plan that addresses pain and symptom management. If someone no longer wants to go on a ventilator, they've had difficulty and they almost didn't come off the last time, we need to treat shortness of breath. Oxygen needs to be provided, morphine. Family needs to know that they will not become addicts. Who's going to assess that person in an emergency? And that needs to be laid out 24/7. Who will be available to assess that person if something happens? And then providing supportive care to the patient, to the family, and also to the staff. So for many individuals, staff is their family. And in terms of that emergency assessment, it's also important that the staff who will respond in that emergency have good communication skills and recognize the presence of MOLST and that a plan was developed. And this is the plan, because a different physician may be on call and may not be aware of the MOLST orders or the care plan. So it's important for us also to recognize the ethical legal requirements of the surrogate. And there's a hierarchy in medical decision-making. If the person has decisional capacity, this always takes precedence. It's what they want today, not what they may have said 20 years ago, but what they want today. If they don't have capacity and the healthcare agent or the surrogate under 1750B is making decisions, they need to use substituted judgment. And what that means is it's not what they want. It has to be based on what the patient values are, their wishes, what mattered most to them. And that needs to guide the decisions. I learned this very early in my career from an 85-year-old woman in the nursing home setting, and she was in what we called health-related facility. Today, it's assisted living. And she said to me, Dr. Bamba, everyone has one opportunity to live. Everyone has one opportunity to die. You need to listen to what I want. My family knows what I want. They need to abide by what I want. And that's the guide. And advanced directives can be used as a guide, but it's so important where patients have the ability to provide input. While they may not be able to talk about life-sustaining treatment and understand it, they can still talk about what matters most to them. I enjoy eating. I want to be able to eat. I enjoy participating in my activities, whatever that might be. If we don't have substituted judgment, then we need to use best interest. And that means balancing burdens and benefits and really understanding what is in the best interest of the person, not the family, not the caregivers, but using wherever we have their values and beliefs. We need to respect that and stand in their shoes, not in anyone else's shoes. Now, what is the responsibility of the surrogate under public health law under 1750B? It's to advocate for efficacious treatment. That means treatment that is going to help the individual, and it has to be based on best interest, if known, or if known, person's interests, including their moral and religious beliefs. So again, if we know what matters most to the individual, we base it there. If not, it's best interest. And the statutory says best interest is the dignity and the uniqueness of the person. We need to preserve, improve, or restore health, and also relieve suffering. And sometimes it's very difficult to balance all of those best interest considerations. And it's important because that's part of the documentation required under 1750B. So let's talk about utilizing shared decision-making and reviewing benefits and burdens. These are 4 questions that I used in my practice, not only at end of life, but for every test. Will this blood test make a difference? Will this x-ray? Will this chemo? Will this surgery? Will this make a difference? How will it help? How will it hurt the patient? Is there hope of getting better? And importantly, asking the corollary, if so, what will life be like afterwards? And what does the patient value? What are their goals? If I were speaking to a physician, my goal is to be the best grandmother I can be. In Polish, it's the best babci. And based on a discussion of what life will be like afterwards, if this treatment and the best hope I could be is to be in a nursing home on a ventilator with a feeding tube, never to know my grandchildren, I would make one decision. But if I could always come back and enjoy my grandchildren, I'm going to make another decision. So that corollary question is always important to ask. So let's talk about the individual orders on the MOLST form. The first one is related to resuscitation preferences. It's important for people to understand what CPR is. It is really all treatments to restore the cardiac and pulmonary function when a person has died. People see the success rate on television, and for many years it looked like everyone could survive. And the success rate for the general population or someone in the ICU or in the OR is different than for the people who are appropriate for MOLST. People with advanced illness, it's less than 2%, but in some of the advanced illness, even less. And when you combine all of them, very, very low, if any chance of survival. For those with moderate frailty, it's less than 2%. You combine those together, the success rate is minimal. And we have the reality of COVID-19, and we saw what happened for individuals who were in group homes. Do not resuscitate is not the same as do not intubate. They are distinct orders. And it's important to clarify, it does not mean do not treat. And many times people's experience is that they think that someone who has a do not resuscitate order will get subpar care. We always care for treatment. We continue the treatments that are working. We will just not do the specific treatment and allow someone to have a natural death. Respiratory support refers to when someone's heart or breathing is still working, but it's just not working well. And the survival rates of using either non-invasive or ventilatory support, really, you need to look at the data, and you need to look at the 6-month mortality rates for your individual person. I've given some data here that you can go back and some studies to look at, but you can see that the mortality rates for very old people, for individuals who have failed non-invasive and then are trached, are fairly high. So it's important to understand the data for your individual person, that decisions are being made about respiratory support. And then with hospitalization transfer, you need, again, that's the reason you need this palliative care plan and a 24/7 plan for assessment, as well as management of pain and symptom, and supporting the staff caring for this individual in whatever setting when an acute issue arises. If they're going to the hospital, then we know that they're going. And if the palliative care plans, then they can go to the hospital and be treated with intensive palliative care measures. This would be another lecture itself in terms of managing conflict, but understanding that you need to have an approach to this crucial conversation to be able to resolve conflict is important. There are certain members of your team that may be better at it. Learn from them and do it both with skill and empathy. Do it with both sides and listen actively, and allow people to explain the source of the conflict. So let's talk about what's important in the OPWDD checklist as required under 1750B, identifying and documenting medical criteria. What I've seen and learned is that oftentimes people don't know how to document properly, and there can be objections because there's insufficient or inadequate information here. So let's talk about what is defined in 1750B as life-sustaining treatment. It's medical treatment to sustain life functions, without which, according to reasonable medical judgment, patient will die within a relatively short period of time. This includes CPR, but also respiratory support on a ventilator, hemodialysis, artificial hydration, and nutrition. The role of the physician is to really document these medical criteria and a concurring physician to a reasonable degree of certainty that either the patient has a terminal condition, is permanently unconscious, or has a medical condition other than IDD that is irreversible and will continue indefinitely. And for that, it would be end-stage COPD, CHF, dementia, and also that the proposed treatment would impose an extraordinary burden. So that's the medical criteria. Let's look at extraordinary burden. The considerations there are that, first and foremost, it's the condition, not the person's developmental disability. And the outcome of the life-sustaining treatment is notwithstanding the person's IDD. So it's really based on the comorbidities that exist. If there's a decision to withhold or withdraw feeding tubes, there are other necessary criteria. And the criteria is that the artificial hydration and nutrition itself imposes an extraordinary burden, or there's no reasonable hope of maintaining life. So those are the criteria that need to be met. I want to talk about using trials appropriately, because this is an important piece of the MOLST program. And really making sure you walk away knowing that there is no distinction medically, ethically, or legally between withholding, with not starting or stopping treatment, withholding or withdrawing. There may be differences in the notifications of withholding and withdrawing, but not in terms of these differences, because if there were, then there wouldn't be an opportunity to have a trial. People would be afraid that they couldn't stop a life-sustaining treatment. And so that's really the basis of having a trial. And a trial is really used when it's medically appropriate. It can be beneficial to the patient, and it's based on what matters most to them. Now, their goals, is it more time, longevity, or is it functionality, restoring function, or comfort care? And if it's started but turns out not to be helpful and doesn't meet the patient's goals, then that treatment can be stopped. But there's additional procedures that need to be in place if the person has intellectual or developmental disabilities. And the question that always arises, when do you need to do a new checklist? Is it needed or not? And so it's important to recognize that if there's a time period to say we're trying this for this period of time, if it doesn't work, we're going to stop, or it doesn't, and there's a specific goal that we want to meet, which is oftentimes the better way of documenting a trial because we don't know how treatment may work, then you don't need to do another checklist. It's not met that time period, not met at that goal, and then you move forward. However, if that trial is open-ended and then decides there's a decision by the authorized surrogate to request withdrawal, then you need to do a new checklist. When do we think about withdrawing treatments? Again, care is never futile. We always take care of patients, but certain treatments under certain circumstances may be inappropriate and futile. And it's legally and ethically appropriate then to stop those treatments when they're no longer beneficial. And remember, the surrogate under 1750B is obligated to provide treatment that is beneficial. And also it's important for the loved one and to take the burden off. It is the underlying disease. It is not the act of withdrawing treatment which causes the death. That's important mostly to make sure that there is no burden after the death of the individual for the decision maker. We're going to talk about feeding tubes because these are difficult conversations in the general population as well as in individuals with IDD. And why are they difficult? Well, it's our culture. Throughout our life, we show our love through food. It really is present for all our holidays. We just had Halloween. We'll be thinking of Thanksgiving, Christmas, Kwanzaa, Hanukkah. All of those important family events are associated with food. Food is associated with pleasure. As people reach the end of their life, they may stop eating. And this is true especially for individuals with advanced illness and frailty. And that can cause family distress or distress to loved ones, particularly those that are actively involved and really love their loved one. And sometimes physicians may start artificial hydration and nutrition even when it's non-beneficial, and it can cause more harm than good. And that's the key point. Surrogates are obligated to provide beneficial treatment. So this is a complex discussion. And as you're having a discussion that's focused on artificial hydration and nutrition, it's important to focus on the underlying disease process. And that's really what's causing the decline. And emphasize the important nature of providing comfort measure, basically feedings that are supported as tolerated, and recognize that people are very concerned about starvation. And you need to address that. And they worry because they think that starvation will hasten death. And it's important to recognize it's that underlying disease and clarifying that withholding artificial hydration and nutrition is not the same as denying food and drink. So my suggestion is really to follow a standard approach to the individual who's not able to maintain nutrition. And that's what we developed in 2004 to support the MOLST program. And we based it on seeing and reviewing the data that we had in Rochester where MOLST was first developed. We saw that there were more and more PEG tubes that were being inserted without having discussions about what mattered most and what was the goal of the feeding tube, and reevaluation was not happening. So we developed guidelines to help our physicians and other clinicians to be able to have these discussions. And this data is reviewed every 2 years. It was last reviewed in early 2022. So the important pieces of a global assessment is to really identify any potentially reversible causes, something that can easily be reversed and the person can enjoy eating again. Attempt any corrective action, and if it doesn't work, then it's important to initiate a family discussion. So let's talk about some of the important elements of global assessment. What would trigger it? And the bedside caregivers can look for this and really bring it to the attention of the rest of the clinical team. A person that's experiencing weight loss, their eating is not as good as it had been. And it's important to know clinicians often overestimate what's eaten. So it's important for the bedside individuals caring for the individual to really notice that. Are pressure sores developing? Do they have feedings that are there? Are they starting to have aspiration or difficulty swallowing? It's important also to know and assess the parameters of nutritional status. Weight change, which we all look for, is there possible fluid imbalance? Has their BMI decreased? And looking at lab tests, have they become abnormal? Albumin, prealbumin, cholesterol, lymphocyte count. It's also important for nursing to take a look at some of the factors that may impede adequate amounts of food. Are there physical limitations, visual problems, chewing problems, swallowing problems, conditions that decrease nutrition, nutrient intake? And some of these are symptoms that need to be managed. And that's why that's part of palliative care integrated in with the underlying disease management. Alterations in taste, new medications that have been started, dry mouth, the food options that are being presented. And certainly there's a need for medical assessment. What are the other problems that may be involved? Underlying dementia, depression, anxiety, apathy, communication problems, the inability to make their needs known, a new neurologic condition. A medical assessment is needed to really understand and identify any underlying illness, do a medication review, see if there's a new prognosis, look for constipation and fecal impaction, which is so common, particularly as people have advanced illness, and certainly something that I saw in the geriatric population I cared for, and obviously to address hydration status. The important thing in the discussion that you have is also to be aware of and integrate disease-specific medical evidence when you're talking about how feeding tubes can help or hurt. And a practical approach is really to base that conversation on the disease-specific evidence and to appreciate and respond to the emotional cues that may come because we are so connected to food in our culture. So some of the key elements for this discussion go back to the 8-step protocol, reviewing the health status, the current health status, the prognosis, the patient values, beliefs, their goals, recognizing that decreased nutrition really is an underlying marker for progressive illness. So as you're talking about that, help people to understand that if you're seeing this, that the disease is progressing, and then take and identify the disease-specific evidence and talk about it, and then making sure that the decision aligns with patient goals. We've seen in the geriatric literature that the goals will tend to move from having more time, longevity, to functionality, preserving or improving functional status, to comfort measures. And then important, if there is a decision to initiate feeding tubes, to align it with goals and to ensure that there's a periodic reassessment. And that's because we see that benefits or failures are likely to occur in the first 3 to 6 months. And as you're looking at it, you're putting that tube in, not as an intervention, but really to align it with a specific goal that is patient-centered. Use those shared decision-making questions that I outlined earlier. So important here. Understand the benefits and burdens and that they vary based on that individual person. So knowing their medical problems, their current health status is so important. And again, aligning that with enabling someone to live longer, longevity, having improved quality of life or functional status, or reversing the disease process, or enabling some curative treatment to occur. This is a tool that I encourage you all to look at. It looks busy, but it really is a summary of all of the medical evidence. And again, it's updated every other year. And we have the evidence base, and I have a link in the resources that you can look at the evidence base and other articles. I'm going to take this because it's hard to read and think through what's on that tool. And I'm going to use the example of stroke. If someone's having trouble with a stroke, you want to look at what was their previous quality of life. If they were going to their program and enjoying time with family and not having trouble swallowing and enjoying food and didn't have many underlying comorbidities, the mild high blood pressure, well-controlled diabetes, cholesterol that was controlled, that stroke is likely to get better. And if they can't swallow, putting in a feeding tube and doing that assessment every 3 to 6 months is absolutely important to do. On the other hand, for someone who has multiple comorbidities, advanced frailty, nearing the end of life, and they have a catastrophic stroke, a palliative approach is much more appropriate, and not putting in a feeding tube, particularly if the goal is to reduce suffering and also to meet what is important under 1750B. The obligation is to provide efficacious treatment. So that's a good example where you can't just use the feeding tubes are good or not good, or we should do it in a stroke or not a stroke. For neurologic disease like ALS, it may be needed to provide medications. Each one of them we need to think about. We're going to talk about advanced dementia in more detail, but I want to also point out advanced cancer and how the evidence has changed and how the disease itself has changed. When I started practice, head and neck cancer was a disease of older people, and we always put in feeding tubes. We now know there's a bimodal impact, and it's impacting and affecting younger people as well as older people. And in younger people, putting in a feeding tube may actually impact their ability to regain their ability to swallow and to speak as part of the treatments can impact that, where in older people, they absolutely will have difficulty getting adequate nutrition going through the therapy. So that's an example of understanding the medical evidence. So we're going to now turn to people with advanced dementia. And it's important to understand, it's beyond the scope of today's time period for our talk, to understand there are tools to help you to assess where people are in the stages of dementia. One such tool is the FAST scale. And if people are needing help with all activities of daily living, are barely speaking or bedbound, they're FAST 7, B, or C, and they're hospice eligible, then they have advanced dementia. And it's not recommended to put in a feeding tube in these individuals, but rather to offer oral assisted feeding as tolerated. I recognize that it takes more time, but that is the best treatment for the individual. And in fact, in an educational initiative called Choosing Wisely, which was an attempt to educate the public about medical evidence, the American Geriatric Society, the American Medical Directors Association, and the American Association of Hospice and Palliative Medical Personnel, Physicians and Nurses, their top #1 recommendation when Choosing Wisely first came out was basically don't put in a feeding tube in someone with advanced dementia because it causes more harm than good. And the evidence has changed over the years that when I started practice to today. It does not result in improved survival. It does not prevent aspiration pneumonia, and it does not improve healing of pressure sores. The evidence shows that it does correlate with pressure ulcer development. And we know from studies that there's more of a use of physical restraints as well as medications to restrain the individual. And as I'm sure you have seen, the tube itself causes physical distress. The last section we're going to talk about, and then we'll open it up to questions, is to have you understand what MOLST is and to appreciate the value of MOLST. MOLST is a secure website. It's a free public health service. Website is nysemolstregistry.com. It's patient-centered. It can be integrated with EMRs. If it's available, it's not required. It's a separate website, so you need basically access to the computer and access to the internet. It takes a standardized process for online completion, and it walks the individuals who are participating in this discussion. It combines that 8-step protocol and all of the checklists. And based on the appropriate person, if it's an individual with developmental disabilities who has capacity, it will direct them to checklist 1. If they lack capacity but have a healthcare proxy, it will direct them to checklist 2. And if they lack capacity and do not have a healthcare proxy, it will prompt to see, do they have capacity to do a healthcare proxy now before MOLST is completed? And if they don't have that capacity, it directs you to 1750B and the OPWD checklist. It's a registry of MOLST forms across the state. And so if it's done in Rochester, it's available on the tip of Long Island. If it's done in the North Country, it's available in Binghamton. A provider can print a PDF of the MOLST form, so it's available for a medical record that's still in paper. It's available to print to give to EMS if the person is still going to the hospital. It's available to print to give it to the individual who is still residing at home. It's been developed in a way to improve quality and patient safety because it doesn't allow incompatible medical orders, and it provides access to MOLST and the discussion in an emergency. And with the form, it's assuming it's been done correctly and it's the end product. But in the MOLST, you'll also be able to see the documentation of capacity determination, all of the elements that are required in the checklist in terms of the clinical documentation, no objections from MHLS, et cetera. And it provides coordinated care and workflow within and across institutions. We particularly saw how valuable it was during COVID-19, particularly with the shift to telemedicine, because prior to that, all of these discussions were done face-to-face. And if you think about the shift to telemedicine and what is possible today for the individuals you care for with advanced illness and access to that physician who may not be at site when there's a discussion that's being done with the 1750B surrogate, and the access to that MHLS has in some parts of our state to being able to see that draft MOLST form before it's signed. You can see how it's valuable, and it has grown exponentially during COVID. We also saw how interested individuals who had completed MOLST reached out to their systems to be able to say, I've learned more about respiratory support. I want to have another discussion to be able to talk about it. So these are the pathways. So you can get access right on your computer. It can link to EMRs. Again, you can print out the PDF for the patient. That registry for the entire state, accessible to all clinicians who are enrolled in the MOLST system, to hospitals, available to EMS in the printed form, but we are working on getting EMS access across the state, and to all the RIOs. And the largest RIO is down in the greater New York City area. It's the largest RIO in the country. And they have developed an API so that even individuals who are not enrolled in the MOLST system can see if there's a do not resuscitate, do not intubate order in an emergency. We have videos that I encourage you to listen to. There's an overview that I did of the program, trying to get a grant. So it sounds like I'm selling MOLST, but I was, and I still am, because I really believe in the value. Dr. Patron is a medical director who used it since initial use of MOLST when they were still in paper records. She talks about how valuable it is from a clinician standpoint. And the last is Jonathan Carmel, who is our attorney at the health department, who speaks of the value from a quality and patient safety perspective. But there are many others that help you to be able to see how MOLST is used. I'm going to quickly go through the resources and hopefully be able to answer any questions that are present. Advanced care planning is on the redesigned compassionatesupport.org website. We developed compassionatesupport.org at the same time we developed MOLST and community conversations on compassionate care and community principles of pain management. But several years ago now, we split it into maintaining advanced care planning, palliative care, hospice on this website, and we split it and integrated it to MOLST.org. So everything about the MOLST program is on this website in collaboration with OPWDD and MHLS, folks from all of the advocates for persons with intellectual and developmental disabilities. We created a special section so that people could get quick access with COVID. Here are multiple references. There's all links to specific websites that you can look at, references, and I just pulled a couple that really talk about supporting the patient's voice and how that really builds the foundation, and a bit of background on New York's approach to MOLST that combines that community conversations on compassionate care and MOLST, and an example in this article way back in 2012 showing how this is so much more important and why having a MOLST supersedes that living will that's present. And then there are a whole host of feeding tube references that I provided for you, and MOLST references. So with that, and videos, I'm sorry, I should mention the videos. There's a whole YouTube channel, but you can look at how thoughtful MOLST discussion should be done. And it's broken down to certain sections. So if you were specific on understanding how to talk about feeding tubes, for example, we've broken that section out. And there's lots of education on completing healthcare proxies. And this is a video that has multiple providers from across the state talking about MOLST, what it is, what it isn't, and why it's valuable. I'm going to open this up to questions at this point. Thank you very much for having me today. Wendy?
Sure, Dr. Bomba, there's a question. Is the OPWDD checklist only for individuals who live in residential settings?
It's for all individuals who have intellectual or developmental disabilities, who lack capacity to make MOLST decisions, and do not have a healthcare proxy. And it doesn't matter where they are living.
Great, thank you. And then a question, are blood transfusions considered life-sustaining treatment?
That is a great question, and it's an important one as you think about individuals who are Jehovah's Witnesses. And it's important to look back to that individual. And so we've had several cases where the guardian is a Jehovah's Witness, but the individual is not. And again, the surrogate decision maker needs to make decisions in accordance to that individual. And so they can be a life-sustaining treatment, and there are individuals who will actually put that in other instructions, but it really only goes there after there's been thoughtful consideration and discussion about it.
Thank you. And then there are a couple of questions, Dr. Bomba, on situations where we have an individual who's in a rehab and is not really considered to be frail or at end of life, maybe older, and the nursing home is saying they routinely request that a MOLST be done for the individual. And this actually happened to me last week, someone who was in some subacute rehab with PT, but not frail, not at end of life. And routinely, the nursing homes are asking that this be completed without a checklist.
So are they asking for individuals who have IDD as well?
Yes.
So that's inappropriate, similar to what I've seen in and why I've really been passionate about this kind of education, where we visited some group homes where they were being initiated for guardians who were nearing end of life and wanted to be able to manage their individual patients. And really, it was really more to support the guardian who wanted to make sure the end of life, decisions were made. It was sort of like, and it sounds like the same nursing homes are using this as an advanced directive on steroids, I would say, doing a MOLST for the future, not based on what's happening today. That's not appropriate. I do know some nursing homes are confusing that, and they're using that to meet requirements that under the law that you need to ask, does someone have a preference about resuscitation when they're admitted to a nursing home? It does not say you need to do a MOLST. There is no requirement in DOH regulations in a nursing home for that to happen. And if it's not appropriate for that individual to have a MOLST, then it's appropriate to educate that nursing home, frankly, so that they understand. And there's lots of slides that you can use with attribution to me, and I'm happy to follow up on those if you have difficulty, that it's not meant for that. And so they are using it as a system-based approach. We're going to have a MOLST on everyone, and that meets our requirement. And that's really not meeting requirement. It was never designed to say, if your heart stops and you stop breathing, do you want us to start it? And that's how some of these decisions are being implemented. It's meant to be a thoughtful discussion. It's meant for people to understand it. And if people want full treatment, there's no reason to have a MOLST. And
Right.
there's no reason for someone who is not appropriate to have one.
Dr. Bomba, this is Erica. I just wanted to ask, just to jump on that one, because it was my question, but it was also because of Wendy asking it and others asking that. How can we then approach maybe the Department of Health in helping, because don't they oversee the nursing homes, at least the public ones? I think the private ones I would think as well. Is that something that could be done?
I think it's an important one. And I think that there's a list of important things that need to happen at the department. I will add that to the list, because I think
Okay.
that is a better systems approach
Right.
to be able to make sure that they understand that.
Thank you.
And I think that has been, I would just say I've approached that in the past, but there's been so much change in leadership and COVID, and so that it hasn't been addressed, but I think it's a system issue.
Thank you.
Thank you. Samantha had a question on dysphagia and feeding tubes. Samantha, was that question answered by Dr. Bomba's discussion, or do you want to talk about that a little more? Okay, well, while we're waiting to hear from Samantha, there's also just a statement, Dr. Bomba, that maybe you want to respond to, that some people feel feeding tubes are inserted only as a matter of convenience for some agencies and nursing facilities.
I totally agree with that statement, and I have concerns about that. And I've shared with many, and I don't know if folks are on the line, but certainly during our ECHO MOLST sessions for individuals with IDD this fall, as I look at my experience and back in the 80s when I was in a nursing home as a medical director and a primary care physician, caring for many people with dementia prior to feeding tubes coming along, and most importantly, feeding tubes being paid for by Medicare, we did careful hand feeding with people sitting around a table, 4 people, individuals. Family came in to assist with feeding, and we did not see pressure sores. We did not have people having recurrent admissions to the hospital. We did not see people getting agitated by having feeding tubes in place. The change I have seen, and that's why we developed the feeding tube guidelines. We saw that increasing as Medicare was paying for these. And I'm concerned because there's more it costs more to have an aide to provide the feeding in that way. And I do think there should be another system issue that I've tried to address, and I have addressed with nursing homes in particular, as well as the DOH, is, what comes first? Is it safety, or is it what the person's wishes are? And so safety does not trump it, it's personal wishes. And if people like to eat, they should be able to eat. And it provides pleasure. So I share the comment. I have concerns. I think that's why I also wanted to point out that the surrogate's obligation is to provide efficacious, beneficial treatment. And if the feeding tube is not going to provide beneficial treatment, then it's not in accordance with 1750B. And how that discussion is held and how much information is given on the medical evidence, it should be based on medical evidence, not the convenience of an agency. That's my personal view.
Thank you. Someone has a question.
I don't know if there's any comments on that from anyone else,
Let's
because
just see if there's anything here.
No, it was my comment about that, because that is of concern. We've had family members of our organization who've had those situations, and the physicians for some of the state agencies have encouraged, if not forced, that issue, to have a feeding tube. And so I think it's been I don't know if that's been resolved, but it is, I think, still an issue. And plus, you don't have the staff that are enough staff to really take the time to feed individuals the way that they should be,
But I think, again, that may be a system issue, Erica, that you and I can take offline, because it's providing non-beneficial treatment based on
Absolutely.
medical evidence. And that's the only way that will change. And the only other option is for people to receive care at home.
Right.
And that's not always feasible, frankly.
There's another feeding tube question. I think you addressed it a little bit in the presentation, but someone writes, hearing that feeding tubes do not assist with avoiding aspiration, when is a feeding tube a good medical recommendation?
So I gave some examples. I used the one example with stroke. When there is someone who is, again, I'm going to use the same example because it's a very important one for your population. Think of someone who is enjoying life, enjoys eating, has well-controlled, medical problems that put them at risk for stroke, high blood pressure, maybe diabetes, cholesterol. They go to program. They're engaging with family, with people in the facility or in the group home, I should say, and they have a stroke. In that for that individual, a feeding tube, and it's a dysphagic stroke, they have trouble swallowing, a feeding tube is absolutely appropriate. And then checking, and the goal is for them to regain their feeding, for the stroke to improve, and oftentimes they will have weakness in their arm or whatever, and reassess them in 3 months. What has happened? Reassess their abilities to swallow. And that's really part of good care for that stroke person. And that's different than the person who is bedbound and has advanced frailty, multiple advanced illnesses, has a catastrophic stroke. And again, differences in these two individuals. And in that setting, a feeding tube is not going to be beneficial. That stroke is they're not going to recover. So it's two different settings, two different individual patients, two different thinking about a feeding tube. I think it's a really good example of when it's non-beneficial treatment, and where that's part of that conversation that needs to be done, and certainly provide one here. I also use the example of head and neck cancer in a young patient, again, with the same kind of dynamic, is maybe has no medical problems and has, de novo tongue cancer and has been healthy. That person with IDD doesn't need a feeding tube because they have a better chance with the treatment that's needed to regain their ability to swallow and to enjoy food versus someone who's older, which is the typical head and neck cancer that is going to need that for nutrition to be able to get to the treatment. And so doing exercises to eat and swallow, that's exercising those muscles. Doing exercises for phonation is going to help them to speak again. Two different kinds of patients. And that's why those examples are ones where you have to take the medical condition where they are on that rainbow. Is it early disease or is it late disease, to be able to make that decision about feeding tubes. I hope I answered the question through those examples again.
Yeah, I think the more examples we hear, the better.
Yeah, another example would be someone who develops ALS and they have dysphagia, but they need it for medications. Part of that discussion would need to be also, at what point would you want to stop using the feeding tubes and do it when they still have the ability to make those decisions? Those are tough discussions. But the more you have those discussions and the decision maker can be part of it. And I'm using an example of someone with IDD who develops ALS, who has capacity, that becomes an issue where you know when to stop, when to start, when to stop, and always to reevaluate the benefits every 3 to 6 months.
Someone else is noting that sometimes if a person has a feeding tube, they can no longer stay in their residence, which can be a big problem in and of itself.
I agree totally. And I think that's another reason that it has to be looked at. And again, one can think about this in terms of 1750B. The responsibility of the surrogate decision maker is to provide to ensure beneficial treatment. And that doesn't mean stopping every life-sustaining treatment where it's non-beneficial. And helping people in those decisions through shared decision-making so that they never feel like they caused the death. That's an important part of what I teach for the general population. It's equally important in this population.
Yes, and I
There's
think
one other. I'm sorry, Wendy, there was a question from Stephen had asked the question probably earlier on that we didn't see, but he says his wife and Stephen are legal guardians for the brother-in-law, and he's at one of our chapters. If something were to happen to him, would Stephen and his wife still need to do a MOLST for him?
The issue is related to capacity. And so if the guardianship says he doesn't have capacity to make medical decisions, then they would be stepping in as the guardian. So it really is dependent on the guardianship papers and the authority, as well as the capacity of the individual. Remember, capacity is task specific. People can have capacity to choose a healthcare agent, and it's different from medical decision making. They may make simple decisions, palliative decisions, but may not be able to make complex decisions. And if he's not ready for a MOLST, and he's not appropriate, I should say, not appropriate for a MOLST, and he loses capacity, then, and if you're the legal guardian that has the power to make healthcare decisions, then you would be the person making decisions on his behalf if he doesn't have the ability to make them now. And I guess I'd read the guardianship papers and see where his capacity is, and does he have the capacity to do a healthcare proxy?
I'm going to jump to a different topic, probably our last question. Is the eMOLST approved to use in OPWDD? And did you say that with the eMOLST, MHLS responds and you know whether they agree or not?
We have, first and foremost, eMOLST is developed for all populations, individuals who have capacity, adults, I should say, adults with or without capacity, healthcare proxy law, Family Healthcare Decisions Act, children, as well as individuals with IDD who lack capacity and must follow 1750B. And so we have parts of our state where everyone who is part of that process, everyone who is involved, has access into the eMOLST system, and they're all able to see together. And that has made a world of difference. So MHLS attorneys are enrolled, the clinical psychologists are enrolled, and again, with COVID, a lot of virtual visits to be able to expedite that. So we have models that exist. So if there is an area of the state that is interested in it, we can connect where there's a lot of experience for several years.
Wonderful. Thank you so much, Dr. Bomba. Erica, is there anything else we want to address before?
Well, no, but we do have a number of other questions or comments that maybe what we could do, because this has really just been so powerful and so informative. And I think people just can't get enough of this kind of information, Dr. Bomba. So maybe what we could do is, if there's some questions that we can help answer, respond to, or share them with you for sure. And then we can respond back to folks.
I'd be happy to do so. And I would say also and encourage folks to consider joining ECHO MOLST for individuals with IDD. We had our first clinic series this fall. Erica and Wendy and others from OPWDD and MHLS were part of the planning committee, as well as clinicians in the field. And when we develop the next series, I know that they will share that. But I want to thank you for having me today.
Oh, this has been wonderful.
Thank
you,
so
Wendy,
much.
too. Thank you
both.
both. And this has been really marvelous. And we'll be inviting you back. I hope you'll continue to be a part of our family.
Thank you. And I hope it'll be in person next time, so we
Yeah.
can do some of these questions in between and with a cup of coffee and
Absolutely.
talk to individuals one-on-one.
That sounds great. Thank you so much. And so now we have lunch, and we indicated earlier that we do have a video that is on the guardianship program. If people are interested, we can also put the link in again. We put it in earlier on in this chat box, so you can go up there and take a look at it. But it doesn't start till it's a separate link. It starts at 12:20. So then you
Eric,
can just
I had one. I'm sorry to interrupt. I had
Sure,
one.
no, sure.
One thought is if someone can print or save the chat and send it to
Yes,
me, that may be the easiest way to take a look at it.
will do.
Yes, we
Will
see
do.
the chat, so we'll get that to you.
Perfect.
This has been great. Thank you. Thank you again, really.
All right.
All right, so
Hopefully we'll
some
see
of
you
us will, right. Some of us will stay on the planning committee, and then we thank everybody.
Erica, you and a couple people are staying on this particular link.
Yeah, the planning committee is just for like 5 or 10 minutes. We just wanted to catch up and chat a
Let
little
me,
bit.
well, I can stay on. I'll just be on mute and then I can hang,
Yeah, oh, no, you can stay on. It's
Yeah.
we just want to talk a little bit about the conference itself and the planning aspects. And
people are,
I'm going to go off, but I saw a question with would I share the slides, and they're fine to share.
okay, great. Yeah, we've been asking everyone for permission because we really don't want to do that without. Thank you
No.
very much for that.
Yeah, no, I
Appreciate it.
just saw that question. So anyway,
Right.
good luck with the rest of your conference.
Oh,
and
thank you so much.
Hey,
You're
Dr. Baba,
welcome.
enjoy
You're
your
welcome to
wedding.
join us.
Well, I'm working on a document.
I know
for
you're working. Yeah,
HBA,
yeah.
so on
Well,
email.
thank you.
But
Have a
thank
good
you.
week.
Thank you very much. Take care.
All righty,
Bye-bye.
thanks. Take
How many-
care.
Bye-bye.
bye-bye, thank you. How many people are on your planning committee? I just want to, people are starting to,
Yeah, so,
Leave.
I think, Stephen can, I think, Steve, you want to ask us anything?
No, I'm fine. Thank you.
Oh, okay, because we're just having a little meeting here.
Well, if you don't mind, I can just listen in if that's all right.
sure.
That's fine. I don't think
Bridget,
there's a problem.
this is Shelley. Do we have to call into a different Zoom link, or
Yes.
is it going to be?
No,
Okay, so
there-
we can just,
you can just, disconnect and go to our website, and the links there for each session going forward. They're all different. I apologize if it's
Okay.
a little confusing to everyone, but the planning committee is meeting right now just
Right,
to,
Steve, this is for the planning committee for the conference. So if you want to, this is not the same link that we're going to use for the video either.
That's so far. That's so far. I'm gonna go off.
Okay, thank you.
Is that everybody, Erica? Let's see. I can probably see if I can. Is Donna on one of yours?
No,
Okay,
Janet.
I'm
Katie,
gonna put her
Melissa.
in the waiting room because I don't know if they're even,
Yeah, they may just have thought to
yeah.
come back later and they didn't.
Is that it? Is everybody else?
Shelley,
I
can we
just, I put
okay.
her in the waiting room. Everybody's good?
I don't know who BH is.
I'm gonna just,
The more the merrier, I guess.
I guess, I'm so sorry.
Gosh, these links, oh my goodness. This has been like unbelievable. The Angel and I've been, that's all we've been doing is trying to respond to the people in the background about the links. Oh,
Well,
I was literally sending out the program and telling people they're online and here's the links.
I know that, me too. And it's just been, I don't know.
I don't know how we can really manage that in the future. Like I said, I hope we can do this in person.
I know, this really causes us to think more. Now, but isn't there an invite link that it
Well,
just automatically?
What I think if we do have to do it again, there is through Zoom, there is a registration link and then everybody gets their own individual link. And then it
Yeah.
could just be the same link through the whole thing.
Right.
But because we chose not to do that, we thought it'd be easier to go to our, just one central location for people to go to find the links.
Oh, it would be just one link. Yeah. So it
Yeah.
would, yeah. Oh,
You know, it's, I don't know.
I'm
I don't know
telling
what
you,
works.
I have such a headache.
I don't know what works for other organizations. I guess I'm just hoping that we can get in person, and our next big meetings are our own board meetings, and that's just one meeting, It's not.
I'm not sure people understood that every session was a brand new link. I really think people, because they're so used to just signing in and being there.
Right.
Yeah.
So I
Right.
think that was a huge learning curve because usually you just
Yeah.
sign in and you're there. So I think the having to
Yeah.
do every session was
Yeah, it is.
just
And it,
not clear,
yeah.
Well, I wondered how it went out because the way I'm finding it is I have the booklet and then I'm having to type in the numbers. There's like not a live link that I have. So I don't know if
No,
because somebody else registered
I'm on
me.
the ARC.
No, but
page.
we've
Very
sent out
easy.
the links. We have sent out the link to the program that's online, and we've sent it so many different ways. And I think
Yeah.
maybe that was also confusing, but if you go
Marcia,
to
it
the
doesn't look like a
program,
regular link. It's just the
Right.
name of the session. And
It
when you
is-
click on it, it lets you in.
right, it is hard. I have to say, it's not I know that people are getting on and but it's a struggle, and it shouldn't be a struggle that no matter
No.
what, it should be clear and somehow, because you don't know where to click, and then you click and it goes to the program, and then you have to know where to click down. But once you study it a little bit, I think people are just jumping in and not thinking about, and then I've been clicking on it all week just to make sure that they're live and that that they're still working. And so I'm getting into all the different, anyway, let's talk about the program. How's it going so far?
So who's Laura Marks?
Oh, I'm gonna put her in the waiting room. Well, she's not there now.
Yeah, I just want to say that I have the ARC New York page up with the whole, each link, and it's so easy. I'm just keeping it open and I go
Yeah.
right on
Exactly.
there. It's a
Yeah.
very easy.
Right.
That's what I
Very
did.
easy.
It took me a while to go back and find it though, in all my emails about the program.
I know.
So, but I found it and here I am.
Yeah.
Perfect.
Me too.
Well, I
Right.
think,
Pretty
I
good
think-
turn.
I think content wise, I think it's fine. I think, I think we're doing well with staying on the timing, which was a thing we talked about.
Yep.
I think that Drew Dudley, I thought he was very interesting and pertinent to who we all are and probably what we all do, because we think we're just in guardianship. You know, and I thought you just, you can never get enough MOLST.
Oh, my goodness, she's so
Great,
good.
great.
She is, yeah. So I think content wise, I think it's pertinent.
Yeah.
Yeah, agreed.
Agreed.
And I'm also
Great.
glad that we stopped at the 3:40 and 3:45. I think adding an additional session, I
Oh, yeah.
didn't realize how much it is on the brain to be sitting in front of a computer. It's, so different than
Yes.
when you're in a room and there's that energy and you're moving around. So that
Right.
was a
right,
wise
right,
decision.
Yeah, good.
Right.
Well,
Right.
it,
I agree.
yeah, and now I hopefully we're gonna have a good turnout tomorrow so that,
Especially since
Hey.
I have a guardianship meeting at 4:00.
okay.
Pile it on, and
Which,
pile it on.
with,
Oh, guardian all the time.
is it with
Not
your
just
chapter?
anything.
Or, I mean, your full chapter?
No, oh my God, no. I would shoot myself. No, just with Duchess.
Oh, my God,
Mhm, mhm.
that's
Can't
all.
do that, you're heading to retirement. You can't-
Huh?
You can't do that, you're heading to retirement.
That's right.
Enjoy those years, right?
No,
Anyway, no,
Yeah.
it's
I
with
think it's been
Duchess.
going really well. The Drew was great. He was a little repetitive, but we've watched him.
yes, we've
closely
seen him so
too.
many times,
Right.
right?
But he still made me laugh out loud, and I
Yes.
still welled up with some of his stories. So I mean,
Yeah.
very impactful. And of course, Dr. Bomber, I love her voice
I
and
do
her
too, yeah.
presentation style. She's so welcoming sound and so
Yes.
real. It's not
Right.
Yeah,
it's not a
I-
lecture, it's a
And
conversation.
there's no stupid question. It's all a safe, like what she was saying to us earlier, just for a few minutes. She said, there's no safe, it's a safe place for people, and she wants people to ask questions, and no
Yeah.
matter what. That's why I was trying to get to Steve's question from the chapter, because now I understand. I know exactly what you're saying about just not understanding the process and also. Angel, we're going back and forth, going, oh my God.
No,
I know,
he does
and I-
not understand the process.
Yeah,
at
it's,
all.
yeah.
It
But
takes a couple presentations to start to even wrap your head around the MOLST, I think.
Yeah.
And I think we could have almost have had a whole second session of just MOLST conversation after this one.
absolutely.
So, and Dr. Bamba is so open to that. So that might be something to consider, just like an open MOLST
Yep.
question where you
Yep.
bring things to her and, we ask her.
We could have another webinar just with her and a couple of hours, I mean, like she's done this before, like the pre-conference that we had, that she
Yeah.
did. I mean,
Well, I
she
think
loves this.
I think we learned that, almost all the time, because I think
Right.
it's good. Yeah, and a variety of ways of doing it, so.
Right, right. And there's more different questions that come up. I
Yeah,
think,
exactly.
I'd like really teach it, like I look the healthcare proxy, if someone has a healthcare proxy, you don't really need,
Right,
all the little nuances that sometimes come up. The feeding tube, I think feeding tubes is a big issue, and that's really good now that we need to really focus on those facilities that are requiring this. We need to really educate them.
Man,
it'll
I
be
love
interesting to
this-
see
this
how
group.
the judges panel works.
Yeah.
Oh, God.
Yeah.
I'm doing a prayer every moment. I just want them to get on. Everyone
time for
get
wine?
there. Yeah, I really could use some, but I think I have such a headache that I think I would explode. But
Erica,
this is good.
in that vein too, I was going to suggest that I think maybe if we could spend just a few minutes talking about anything we need to about the afternoon, and then have us all have some time to get offline and just
Right.
breathe a little bit and have some
Yes.
lunch or take a walk so that we can rest before.
I
Right,
agree. I 100%.
Agree.
So, yeah, I think I'm going to be introducing the judges panel and the other the next two panels.
okay,
I will be introducing, and there shouldn't be, too much. I think it's going to be very interesting. We met with the judges already. 3 out of the 4 judges were there. They're lovely. They're allowing the recording, in the beginning, they weren't, they were like, why are you recording the pre-planning phase of this? And we just said, we just thought that it would be helpful just to understand what you're going to be talking about with Tara. Tara is all over. I have no idea where she is, but she'll be great with this. And we have questions that were developed together. So it should be very good, I think, in talking about the guardianship and this, we're talking a lot about how are the courts going to view this and how are they doing it now in terms of supported decision-making? Is that going to be the default
Right.
versus guardianship? I mean, I think that's really the question. And then also bringing up the thing that we just asked all of you to comment on, some of you to comment on actually on whether or not virtual versus in-person appearances, are something. And we know that Westchester is absolutely doing that now. They're coming back to the court and they're requiring it. But, there'll be times when they feel like it's not appropriate, not in the best interest of the individual. So I think the flexibility should be
Sounds
there.
good. Is
Hopefully
there
this
anything the
morning-
committee needs to be concerned about with the
No.
afternoon then?
No, I think everything is good. I think I think they're two really good workshops. So I think it's
Yeah.
gonna be.
And
I
I'm
just-
hoping with this morning, people are getting the sort of like, oh, I need to click on the other link, or, oh, I
Right,
need to,
right.
this is how I get from A to B. Hopefully there was a little bit
I
of a
know.
learning curve that will be better this afternoon in terms of people
Right.
finding
Yeah.
their way.
So
I
hang
hope
in
so.
there, Angel and Erica. and
Yeah, we
Bridget.
will.
Yeah.
We
Keep doing
will.
the good work with
We
everything.
will,
Okay.
and feel
Very
free to ask questions or, jump in anytime you feel you want to. And Bridget, you're doing a
Okay.
good job there, kiddo.
Or
So-
go
See you at
stretch.
1.
All
So
right,
we're gonna
see you
get
at
out, and at 12:20, you're gonna show the video, right?
yeah.
Or
Right,
Brian
so
is?
if you didn't see the video yet, please do. Please join
Okay.
that link.
Yeah,
Great.
I'm getting out.
Thank
I
you.
need to get out.
Thank you, everyone.
Gone
Bye,
for a
see you
while.
soon.
Buddy.
Thanks,
All
guys.
right,
Bye-bye.
guys, see you later.
Bye.
Thank you.